Hello and welcome very much to our webinar this morning entitled Do Ontarians Have the Alcohol Policy They Deserve? My name is John Atkinson. I'm the Executive Director of the Ontario Public Health Association, and we're really thrilled to be holding today's webinar. Before we begin, next slide. I would like to take a moment to acknowledge that I am a first-generation Canadian and a settler on the lands of the Erie, Neutral, Huron-Wendat, and Haudenosaunee peoples. OPHA headquarters is also located here. Today, this land is also known as Hamilton, Ontario, and the covenant that was written to ensure that the resources and the land around the Great Lakes would be cared for and shared amongst Indigenous and settler peoples. That's called the Dish with One Spoon Wampum Belt. There's also another treaty, which is called the Between the Lakes Purchase, and that was signed in 1792 between the Crown and the Mississaugas of the Credit First Nation. I don't have to tell you, but I will. We know that colonialism and its legacy is complex, and while it certainly allowed the opportunity for my family to live here, the removal of Indigenous peoples from their homes and their history has had and does have lasting and profound impacts. So while this land acknowledgement is really only a start towards reconciliation, I just want to share that OPHA is committed to listening, learning, and where appropriate, partnering with Indigenous organizations, leaders, and communities to help pursue meaningful action towards reconciliation, as well as address current inequities and injustices that Indigenous people face in Canada today. For those of you joining us today who are new to OPHA, I'd like to share a brief mention of who we are. The Ontario Public Health Association is a member-driven, non-partisan charitable organization, and we focus on providing leadership around issues affecting the public's health and strengthening the impact of those who are active in public and community health throughout Ontario. If you'd like to stay up to date with us or our work or get involved, please sign up for our e-bulletin on our website. If you would like to get even involved in our initiatives, such as advocacy efforts, policy work, training, capacity building, we also have an option that you can join as a member. We're a membership-driven organization. And now on with today's webinar. I'm really pleased to welcome our expert speakers for today's webinar. I'd like to welcome Dr. Norman Giesbrecht. Dr. Giesbrecht is an emeritus scientist with the Institute for Mental Health Policy and Research at CAMH in Toronto and an adjunct professor at the Dalla Lana School of Public Health, University of Toronto. Norman was a founding investigator on the CAPE project team, the Canadian Alcohol Policy Evaluation Project team. He has served on numerous national and international research teams, and his work has been dedicated to producing high-quality, evidence-based research to inform the prevention of alcohol-caused harms. Thank you also for joining us, Dr. Tim Stockwell. Dr. Stockwell was director of the Canadian Institute for Substance Use Research, formerly known as the Centre for Addictions Research of BC, since its inception in 2004 until 2020. He led Australia's National Drug Research Institute as deputy director and then director for 16 years. Tim is a fellow of the Royal Society of Canada and received the 2013 E.M. Jelinek Memorial Award for outstanding research on social, cultural, and policy aspects of alcohol. He is currently a scientist with NDRI and professor emeritus in psychology at the University of Victoria. And finally, I'd like to welcome Elizabeth Farku. Elizabeth's a researcher at the Canadian Institute for Substance Use Research and a medical student at the Mayo Clinic Alex School of Medicine. She's also an active member of the Toronto Cancer Prevention Coalition's Alcohol Working Group Elizabeth has contributed to a review on the effect of alcohol policies on suicide, an educational curriculum on alcohol and cancer for middle school students, as well as the World Health Organization's global information system on alcohol and health. And now I will pass it over to you, our speakers for today. Thank you so much.
Thank you very much, John, for that introduction. I want to say a few words, first of all, about our supporters. And you can see that Health Canada, Public Health Agency of Canada, and also in-kind support from co-investigator institutions, knowledge users, and government stakeholders. Next slide.
And Norman, do you mind turning your camera on?
No problem.
Thank you.
How's that?
Perfect.
This presentation will provide a brief overview of the CAPE project and policy domains, and the results and recommendations specific to Ontario to improve alcohol policy and thus reduce harms. And we're going to talk mainly about these 4 domains as listed here: pricing and taxation, physical availability, marketing and advertising, and screening and treatment interventions. Next slide. What does CAPE offer? It provides a rigorous assessment of how well each level of government in Canada is implementing policies proven to reduce harm from alcohol use. And this is the 3rd time the assessment has been performed and includes all provinces and territories in the federal level. And in my view, I think it's getting better each time we do it. CAPE offers accessible, evidence-based, up-to-date information for policymakers, researchers, and NGOs. Systematic policy comparisons between Canadian jurisdictions and over time, and a platform for informing the public about effective alcohol policies, and a mechanism for keeping the public health approach to alcohol policy on government agendas, and that's a big challenge. Community of practice with more than 350 members facilitating learning events and knowledge exchange. Next slide, please. People in Ontario consume the equivalent of 457 standard drinks of alcohol per person aged 15 and older. If you used as a denominator the people who drink in the past year, this number would be substantially higher. Alcohol has led to 6,202 deaths. And I think in the same year in Ontario, there are roughly about 3,500 deaths from opioids. 38,000 years of productive life lost and 319,000 hospital admissions. The economic cost of alcohol in Ontario is estimated to be $7.1 billion. The net revenue from alcohol is totaled $5.1 billion. So there's a deficit of $1.9 billion per year. It is clear that the costs of alcohol exceed revenues. The next slide presents this in more detail. Using data from Stats Canada and the Canadian Substance Use Costs and Harms Study, we see that every province and territory in Canada runs a deficit from alcohol. The last row on the table shows the loss per standard drink. In short, alcohol sales do not pay their way. Next slide. The WHO recommended tightening alcohol regulations during the pandemic with a cost-effective and easy-to-implement policies to reduce alcohol attributable burden of disease during a time when much of the population was stressed, anxious. However, we observed the opposite, relaxation. There are many policies in place to ease accessibility of alcohol during the pandemic. For example, expansion of alcohol sales in grocery and convenience stores and online, as well as extended trading hours, alcohol home delivery by third parties such as Uber Eats, and alcohol takeout. In addition, we saw a continued decline in government-run outlets in Ontario, BC, and New Brunswick, and with a move toward privatization, for example, in Saskatchewan, full privatization. Some of the more positive trends include great interest in minimum pricing policies and alcohol sales taxes in some provinces, such as Newfoundland and Manitoba, Government and territorial alcohol strategies and action plans being released and in development. Newfoundland, Northwest Territories, PEI, and Saskatchewan. Next slide. CAPE provides a rigorous methodological process which involves developing and then applying a scoring rubric in order to produce CAPE scores. The rubric is a template that details the policy indicators for which we collect and score data. These indicators are considered the best practices are grouped into policy domains. The domains are based on broad policy areas with well-established and evidence showing positive impacts for public health. As the research has evolved, so too have the policies included in CAPE. There are now over 300 indicators evaluated as part of CAPE, 210 for the provinces and territories, and 93 for the federal government. Updated evidence such as labels and pricing informed CAPE 3 domains and indicators, which resulted in a new domain ranking compared to CAPE 2. It is important to note that the results are not directly comparable between CAPE 3 and CAPE 2, as the evidence and policy indicators are updated each time, but they reflect the overall direction of government approaches to alcohol policy addressing the harms in Canada. A comprehensive description of the project methodology and summary of the evidence is available on the website. Before we move to the results, here's a quick look at the policy domains included in CAPE 3. There are 10 domains included in the federal assessment and 11 included in the provincial and territorial assessment. The stars here indicate the domains that will be presented in detail today. Details of the 300 plus CAPE indicators can be found in the scoring rubric. It is important to remember that policy domains assessed by CAPE form part of a comprehensive and synergistic approach to preventing and reducing different types of alcohol harms. It should be noted that when presenting in various knowledge products from CAPE that form the CAPE domains will be presented in rank order based on the weighting of effectiveness and scope, highest overall impact. Let's try to keep this in mind as we move through the different domain results. And now I'm going to turn it over to Tim Stockwell.
Thank you, Norman. Good morning and a pleasure to be part of this webinar. Starting with a slide comparing the overall scores, CAPE scores for all the jurisdictions. So we include the territories as well as the provinces, and you'll see before you not a terribly impressive set of scores. Not one of them gets, I think the highest one there is 42%. So this is the overall score of the indicators across those 11 domains. These are a little lower, although the measures have changed a little bit. Some of them are comparable, and sadly the direction of change mostly has been a little bit downwards. So we see Ontario with 40% overall score. Not the worst, but you know, anyway, next slide. We're going to go into a little more detail. Slightly more encouraging is that if you look at best practices, the best existing practices on the indicators across Canada, and you added all those up for an imaginary jurisdiction, they would have achieved 80% or a school grade of A minus. So it's not that the standards that we're applying in our assessment are unrealistic. They are achievable. There's a jurisdiction somewhere in Canada is doing nearly all of them, but sadly it's very patchy. Next slide, please. So drilling down a little bit for across those domains, 11 domains that Norman described, you can see the school grades and percentage scores for each one. You see the very last one, monitoring and reporting. Ontario is doing a great job of tracking the harms from alcohol. There's good resources available for that. But in terms of action on the big hitters, the policies with the greatest weight, like pricing and taxation, availability, the control system, the scores are pretty low. Liquor law enforcement, screening and treatment interventions get C-, impaired driving countermeasures above 50%, D-. But so anyway, that gives a little breakdown. So I'm going to go into a little detail on the pricing and taxation. So we go back one slide. So thank you, trying to anticipate where I'm going as I freewheel. We're going to focus on these 4 domains in this presentation. I'll do the first one. Elizabeth is going to focus on the next 3. Next slide, please. And an overview of why pricing and taxation is important. It is, as I just said, the most heavily weighted. We give the most in that total score. Pricing and taxation contributes more to because it's weighted to reflect the extent of evidence of effectiveness. So we know it's a highly effective strategy, whether prices are raised directly through minimum price regulations or through taxation. It's a highly effective strategy to reduce consumption and in turn alcohol-caused health and social harms. To achieve those benefits, prices have to be maintained over time. They mustn't decrease. Alcohol shouldn't be cheaper, the taxes shouldn't be lower relative to other goods. So it's generally a very cost-effective method to reduce harm. The best, most precise kinds of approach are to use minimum unit pricing. So you put a price on the amount of ethanol, the stuff that does you harm, and there's a floor price, minimum price by which it can go, because cheap alcohol is sought by the heaviest drinkers, the people who are most likely to experience harm, or to do that occasionally, to go out and get drunk on one occasion. So the other strategies are alcohol sales taxes, retail markups through the monopolies. The governments in, I guess, all Canadian jurisdictions do still have a monopoly on the distribution of alcohol, and so they can place markups, the beginning prices, like wholesale prices, that the retailers, the people running bars, restaurants, and liquor stores, that's the starting price for the products that they're selling. So the government still does have quite a control there. Going to the next slide, just go into a little more detail. So it's very important to understand that alcohol harms are experienced disproportionately by people on low incomes and people with other vulnerabilities, mental health, and so forth. There's an extensive body of work now on minimum pricing or minimum unit pricing in Canada, Australia, and Scotland, which is very positive in the sense that particularly minimum unit pricing will effectively reduce consumption and harm very effectively, particularly for heavier drinkers and disproportionately for those on low income. So in communities with average low household income, we've been able to show in Canada that the reductions in hospitalizations and deaths are disproportionately large compared with the impact on consumption. So it's like, this is the harm paradox. People on low incomes tend to drink a bit less than people on higher incomes, but they have more harm from their drinking, and minimum pricing directly targets that. It's important to remember a lot of the harm from alcohol is experienced by others, not the drinkers. There's a lot of harm to the heavy drinkers, but also those around them. And these strategies have benefits across the whole community. We know that minimum pricing impacts people with alcohol use disorders. It prevents people developing alcohol use disorders in the future. And it has the other beneficial effects of reduced crimes and social problems. And as I mentioned, benefits for non-drinkers. Managed alcohol programs, which, of course, you in Ontario have many. I mean, you have pioneered managed alcohol programs. Countries across the world are trying to copy that example. Where there's concern that there could be negative consequences for people, vulnerable people, people on low incomes, managed alcohol programs are designed for people with severe alcohol use disorders and homelessness, and they can mitigate these feared harms. But having said that, the evidence is that actually minimum pricing reduces health inequalities. It's one of the most efficient and effective ways of reducing health inequalities in Canadian society. Another point here is that governments, the distribution monopolies, collect extra revenue through the markups, and depends on the exact system, and also the some of the tax revenue, and that can be channeled into improved services for people with alcohol problems or with other vulnerabilities. Next slide, please. So, just going to dive into the scores for just pricing and taxation, bearing in mind this is perhaps the most important domain. Sadly, Ontario scores, well, it's below halfway compared with the other provinces, none of which do a very effective job. PEI is the only one that gets above 50% because they have a very high sales tax on alcohol compared with other countries. And I'm going to break down the reason for Ontario only getting 37%. Having said the average score nationally is 29%, so it's above average. There's some places that are worse. Next slide. Let's just drill down. So this breaks the overall score for pricing and taxation into 4 areas. So there's the level of minimum prices for off-premise outlets, the level of minimum prices for on-premise, for bars and restaurants, how the overall general price of alcohol tracks against inflation, the price rises for goods in general, and then specifically looking at how high the sales taxes are for alcohol versus other sales taxes, and the extent of markups that the distribution monopoly can levy. We go to the next slide, please. And this will give a little summary of the red mentions are not so good, the green ones areas of sometimes excellence. Sadly, there's a few more red than green. So minimum pricing is lower than recommended. We'll show that in more detail. It is precisely tied to the amount of ethanol in drinks, but for high strength beer only, and automatically indexed to inflation for all beverages except beer. Unfortunately, there's some huge loopholes. So there's this thing of delisting products. So where the government liquor stores are having trouble selling products, they will put them in a little display often near the checkout with sometimes wildly reduced discounted prices just to clear them out. So that's making world-class cheap alcohol available in supposedly highly priced Canadian government liquor stores. There's also often volume discounts. So the more you purchase, the lower the cost per standard drink for some products. Minimum pricing for on-premise bars and restaurants is again quite low. It's not at all tied to ethanol content, and it doesn't get indexed to inflation. So the tendency is for it to become cheaper less expensive over time. Unfortunately, prices in general have not been tracking inflation. They've not kept pace with inflation, the price of goods for more generally, with the exception of beer and spirits sold in bars and restaurants, and that's a minority of sales, but 80% of sales goes through, is off-premise. Alcohol taxes and markups. Alcohol is not taxed at a higher rate than other consumer goods, whether for on-premise or off-premise. So there's lots of tips and clues there how things could be better, and those are some of the reasons why there's such a low score for pricing and taxation. Next slide. And my final slide just summarizes the minimum prices, which are so important, as mentioned before, showing how low they are for each beverage type compared with kind of a good recommended minimum price level according to the best practices in Canada, but overseas. So if you compare with Scotland or Ireland or parts of Australia where there's minimum prices, we've set the recommended level at like an international good quality recommended level. And sadly, in every case, the actual minimum prices in Ontario are considerably lower. So there's massive gains that could be made just in this area alone. So I'll hand over to Elizabeth. Thank you.
Dr. Stockwell, I think there's one more slide on pricing and taxation if you wanted to go over that.
Goodness, so there is, sorry. Okay, that's apologies, just the key recommendations. Base minimum prices for all alcohol sold on ethanol content, so there's minimum unit pricing. Set the minimum prices at those recommended levels, just shown that's just over $2 a standard drink for off-premise, for liquor outlet, liquor stores, just over $4 for bars and restaurants. These prices need to be indexed to inflation so they don't decay over time. Alcohol should be taxed at a higher rate than other consumer goods, which it isn't at the moment. Yes, thanks, Elizabeth, over to you.
Thank you, Dr. Stockwell. So I'm going to be talking first about physical availability. So physical availability refers to the number of off-premise retail outlets. So that's somewhere where you're purchasing alcohol but not consuming it there. So that would be something like a liquor store, as well as on-premise licensed establishments such as restaurants or bars. And we do this based on the amount in a certain geographical area. Physical availability also includes trading hours and days that these outlets and establishments are open. It also includes where outlets and establishments can be located from a legislative perspective, as well as which types of businesses are permitted to sell alcohol. So for example, whether grocery stores or convenience stores are allowed to sell alcohol. Limiting the physical availability of alcohol with reduced outlet density and trading hours is a key population level intervention that can decrease consumption and prevent alcohol harms. It's worth noting that takeout and home delivery increase the spatial and temporal availability of alcohol, especially to minors, and has been associated with increased consumption and harms. And this has been particularly problematic with the COVID-19 pandemic, which saw an expansion of takeout and home delivery of alcohol. Next slide. So if we look at physical availability, we can see that the average score across Canada was 40%, and Ontario scored 43%, so just slightly above average, but still a failing grade. Next slide. So here I'm going to talk about the different indicators we looked at. So starting with the blue bar, that represents off-premise density. And so for this indicator, we looked specifically at whether there are provincially mandated limits on off-premise outlet density. So for example, whether there's limits on population density or based on the number of outlets. We also looked at outlet placement. So for example, whether there are legislated mandated minimum distance from schools or community centers. And specifically for off-premise outlets, the density cap was defined as 2 outlets or fewer per 10,000 people aged 15 or older. And these can include private, government-run, and ferment on-premise outlets. In terms of the hours, we looked at whether hours of alcohol sale are mandated and how they compared to an ideal of not being open before 11 a.m. or extending hours beyond 8 p.m. Also, they needed to be fewer than 7 days of sale per week and open less than the maximum possible hours of operation per week. Now, if we look at the orange bar, this represents on-premise, and it's very similar concepts as to off-premise, so I won't go over those in detail, but just some differences. The density cap for on-premise outlets was defined as 15 licensed establishments or fewer per 10,000 people aged 15 or older. And the ideal hours for sale were that it would not extend beyond 1 a.m. the following day. Also, it's worth noting that points were removed if there were discretionary exemptions or extensions that were granted to hours or days of sale, such as extending hours of operation for a special community event. And finally, if we look at the gray bar, this represents takeout and home delivery of alcohol. And so for this indicator, we looked at whether there are regulations prohibiting home delivery of alcohol for off-premise retail outlets and on-premise establishments. And we looked at whether there's a requirement that alcohol home delivery be provided only by the retailer or licensee, rather than a third-party delivery service such as Uber Eats. An ideal was that the requirements around the purchase of food must be well-defined and be adequate. Next slide. So here is just a summary of the strengths and weaknesses in terms of physical availability of alcohol in Ontario. So in terms of off-premise, the level of population-based off-premise outlet density is near recommended limits in Ontario. Ontario does have legislative powers to set limits for off-premise outlet density and sets a cap on grocery store licenses, so that is a positive. The hours of sale, however, do extend longer than recommended limits. And while there are voluntary restrictions on outlet placements to which the LCBO does adhere, there are not mandated restrictions. In terms of on-premise, the level of population-based on-premise outlet density does meet recommended limits. Density limits do not apply to all premises, however, and the hours of sale do extend longer than recommended limits, that is before 11 a.m. or after 1 a.m. And finally, in terms of takeout and home delivery, Ontario is really failing from this perspective. Ontario does permit alcohol home delivery, including by a third party, such as Uber Eats, and takeout of alcohol from on-premise establishments is permitted, although it does require a food purchase with the order. Next slide. So in terms of the key recommendations, we recommend that Ontario reduce existing density of off-premise outlets and strengthen density limits for off-premise outlets and introduce density limits for on-premise establishments. We also recommend that Ontario introduce placement limits for all premises. So for example, restricting placement of these outlets near schools, reducing and legislating maximum trading hours allowed per week, and restricting alcohol sales before 11 a.m. and after 8 p.m. for the off-premise outlets and 1 a.m. for the on-premise. And finally, we recommend Ontario prohibit on-premise alcohol takeout and prohibit the home delivery of alcohol, including by a third party. And it's worth noting that if Ontario implemented all the best existing physical availability policies across Canada's provinces and territories, the score could increase from a failing grade of 43% to 82%, which is an A-. So lots of room for improvement if Ontario looks to other provinces and territories. Next slide. So now we'll be talking about marketing and advertising controls. So a ban or comprehensive restrictions on alcohol marketing is one of the most effective and cost-effective policies for reducing the harms caused by alcohol. Restrictions can apply to the volume of content, the content itself, the placement of advertisements, as well as restrictions on price-based promotions. However, it's worth noting that the effectiveness is contingent on restrictions applying to all advertisers and that there's an independent regulatory body that monitors and enforces the restrictions. Next slide. So here we can see that the average score for marketing and advertising across Canada was very poor at 33%. Ontario is above average at 42%, although it's still a failing grade. Next slide. So going into the details of this, if we look at the blue bar, this refers to advertising restrictions. So these include restrictions on alcohol marketing, which can include, as I said, the volume of restrictions. So for example, the number of advertisements or the percent of advertisement space that's occupied by alcohol ads across all media types. So these include broadcast, online, social media. It also includes restrictions on the advertisement content itself, as well as the placement of the advertisement. So for example, there might be restrictions prohibiting alcohol ads near schools or treatment centers, bans on alcohol ads in media where the target audience is under the minimum legal drinking age. And it can also include restrictions on price-based promotions. We also looked at whether there's prohibition of alcohol advertisements by non-licensees. So these include third parties not involved in the production, manufacturing, or sale of alcohol, such as food delivery services such as Uber Eats. And we also looked at whether these restrictions apply to all advertisers. So these can include, for example, government retailers, private retailers, and licensees, ferment on-premise outlets, manufacturers, and various other people that sell alcohol. And looking at the orange bars, we see that this is enforcement of advertising restrictions. So for this indicator, we looked at whether there's a mandatory pre-screening process conducted by a representative that's independent from the alcohol industry and alcohol sales. We looked at whether there's a specific independent authority responsible for enforcement and an online complaint system that's adjudicated efficiently within 30 days of the complaint first being filed. We also looked at whether penalties for violations of advertising and marketing regulations are commensurate with the severity of the violation and escalate with the frequency of the violation. And finally, we also looked at whether listings included the advertiser name and nature of the violation and whether that was publicly available to the public to look at. Next slide. So looking at strengths and weaknesses for marketing and advertising in Ontario, we can see that from an advertising restriction perspective, there is no restriction on the volume of advertisements for alcohol advertisements in Ontario. Ontario does have content restrictions that go beyond the federal CRTC code for all media types, which is a positive. It also does have restrictions on the placement of alcohol ads, such as being near schools or in media with youth as a target audience. Ontario does have a ban on price-based promotions, so those that advertise cheap drinks or volume-based discounts. However, there are no restrictions on third-party advertisers, as I mentioned, and restrictions do not apply to all advertisers. From an enforcement perspective, there is no mandatory pre-screening of alcohol ads across media types and advertisers. There is an independent authority responsible for enforcement, but some advertisers, such as government stores, are exempt from this. And there's no specific authority independent of the alcohol industry that's responsible for enforcement of the advertiser. And penalties for advertising violations are both commensurate with the severity of the violation and escalate for repeated violations. So that is a positive. And finally, listing of violations are publicly available, which is important. Next slide. So going over the key recommendations for marketing and advertising controls. We recommend that Ontario implement restrictions on the advertising quantity. So this could include ad bans or volume restrictions across all advertisers. So these include government retailers, non-licenses and third parties, and all media types, including online and social media. We also recommend that Ontario appoint an independent health-focused enforcement authority to conduct mandatory pre-screening of all alcohol advertisements and extend responsive online complaint systems to cover all advertisers, including the LCBO. And again, it's worth noting that if Ontario implemented all the best existing marketing and advertising control policies across Canada, their score could increase from a failing grade of 42% to 72%, which is a B-. So again, lots of room for improvement. And next slide. And the final domain I'll be talking about is screening and treatment interventions. So evidence-based government-endorsed information and guidance on alcohol can provide an important upstream framework for a range of prevention, education, and health promotion initiatives in both clinical and non-clinical settings. SBIR, also known as brief intervention and referral, in healthcare settings and use of online self-guided SBIR resources are effective in reducing alcohol consumption, particularly among those with early stage or less severe alcohol dependence. And it's worth noting that SBIR is also useful in general to screen for alcohol use, given that there's no safe level of alcohol consumption and people may be drinking at very risky levels, but not necessarily meeting criteria for alcohol use disorder, for example. And finally, inpatient and outpatient treatment services, such as withdrawal management programs and harm reduction services, such as managed alcohol programs, have demonstrated effectiveness in reducing the harms associated with alcohol use. Next slide. So here we can see that the average score for screening and treatment interventions across Canada was much higher than other domains at 67%, and Ontario was actually below average, scoring at 62%. Next slide. So here, going into more detail, so we can see the blue bar represents population level guidance, screening tools, and services. And we can see that Ontario is really doing very, very poorly with this indicator. So for this indicator, we looked at level of government's adoption of the most recent evidence-based national drinking guidance. So what this means specifically is an official statement from government acknowledging their support and commitment to using the guidance in their jurisdiction and allowing funding to be allocated to activities around the guidance or their promotion. For this indicator, we also looked at whether screening, brief intervention, and referral training is available for healthcare professionals and is provincially funded. We also looked at whether there are online SBIR resources that are developed or hosted by the provincial government that are readily available for individuals to use. And we also looked at whether the resources are hosted and developed independently from the alcohol industry. For the orange indicator, this is treatment and harm reduction services, and we can see that Ontario is actually doing great. It's 100%. So this assessed whether there are publicly funded alcohol withdrawal management or detox programs, and whether there are inpatient and outpatient treatment services that go beyond 12-step peer-to-peer models. And for this indicator, we also looked at whether there are permanent publicly funded managed alcohol programs. Next slide. So in terms of strengths and weaknesses in Ontario for this, in terms of a population level guidance, screening tools and services, as I said, Ontario is doing pretty poorly in this indicator. So there are no SBI services by healthcare professionals available. There are no SBIR training for healthcare professionals available. There's no active government SBIR tools available online. And there is an informal endorsement of alcohol guidance in place that was during the data collection period, which is worth noting. This would have been Canada's 2011 low risk drinking guidelines and not the new guidance that was just recently released. And it's worth noting this is an informal endorsement. And so a formal endorsement is much preferred. In terms of treatment and harm reduction services, as I mentioned, Ontario is doing very well. So there is publicly funded alcohol withdrawal management and detox services. There is inpatient and outpatient services that go beyond the 12-step peer-to-peer model, and there are publicly funded permanent managed alcohol programs. Next slide. So in terms of the key recommendations for this domain, we would recommend that Ontario formally adopts the most recent evidence-based national alcohol guidance with an official statement of support. And we'd also recommend that Ontario provide health professionals with screening, brief intervention, and referral training, ensure availability of in-person or online SBIR services with health professionals, and develop or host online self-guided SBIR resources. And again, just showing here that if Ontario implemented all the best existing screening and treatment policies across Canada, its score could increase from a 62% to a 97%, which is an A+. So again, just that recurring theme that if Ontario looks to other provinces and uses them as a guide, it can increase its score. And with that, I will turn it back to Dr. Norman Gieschbredt for a conclusion.
Next slide, please. So I'd like to spend a few minutes just talking about what Ontario is doing well. You can see that off-premise minimum pricing automatically indexed to inflation except for beer. High strength beer tied precisely to ethanol content. Outlet density near recommended limits for off-premise, and it meets limits for on-premise. A cap on grocery store licenses. However, this will change dramatically if alcohol is permitted into corner stores. Sandy's law requiring mandatory signage for FASD, and many policies meet or are close to recommended for penalties for liquor control and licensing ad violations, alcohol sales and service training program, and monitoring and reporting. Next slide. So you can see that there's also a number of areas where the recommendations could be implemented to change the scores for Ontario with regard to the control system, as noted here, health and safety messaging, enhanced alcohol labeling as a manufacturer requirement, on-site health and safety messaging and signage and posters to go beyond Sandy's law, for example, to refer to cancer and violence, for example. The ministry delivering the variety of health and safety message campaigns beyond holiday themes, at least annually, implement a standalone government-endorsed alcohol strategy. And there was some talk of this strategy, I think about 4 years ago, before the pandemic. And that could be hopefully rejuvenated and enhanced and implemented. And finally, perform annual public reporting through a centralized database with tailored KT activities at least 2 years annually, every 2 years. Next slide. Before I hand it over to OPHA to lead the Q&A, I'd like to mention the Cape Community of Practice, which is launched in January 2022, and now has more than 350 members with a diversity of affiliations across all provinces and territories. The Community of Practice provides opportunities for knowledge sharing, connections, collaborations, and professional development. There is also an active working group on the topic of alcohol warning labels, which is a very topical issue right now because there is a second reading. It's going to a committee right now. If you'd like to join, visit the website to sign up or email us for more information. And now I'll turn it to John Atkinson to lead the Q&A. Thank you.